Naloxone saves lives, period. There are doses of naloxone that range from 0.4 milligrams to 8 milligrams, and new formulations of medications like nalmefene that are even stronger. When people refer to certain doses of naloxone as high dose, it's kind of slang. It isn't a medically accurate term. What we should call it is higher dose naloxone. The amount of medication and how it's administered determine its strength. You can give it through the nose, in the vein, or in the muscle. Next, we'll cover what the right dose is. There are a few variables that go into deciding the right dose of naloxone. We have to talk about different patient populations and routes of administration. The most effective one is through a vein. The second most effective is through a muscle. And the third, through the nose. Doses through a vein or the muscle will typically be lower, from 0.4 milligrams to 2 milligrams, because they have a more direct route to the bloodstream. Doses through the nose will be higher, like 4 milligrams or 8 milligrams, because they need to be absorbed through the mucous membranes and into the bloodstream. If they've been using through the nose for a while, they may have built up scar tissue, which reduces the amount of medication that's absorbed. Next, we'll cover patient populations. The other variable to naloxone effectiveness is the type of patient receiving the medication. This is based on how much opioids a person has been using, how often, and for how long. People who don't use opioids, infrequently use opioids, or use opioids in small doses, we call opioid naive. Use should be viewed on a scale from somebody that's opioid naive to somebody that uses so much they're physically dependent. Populations of opioid users will respond differently to different doses of naloxone. We'll get into specifics in the next video. People who regularly use opioids often develop a physical dependence. They develop a tolerance to opioids, and then they need to use more. That euphoric effect dissipates quickly. In simple words, they become numb to the effects of the opioids and have to up their dose just to feel normal. When tolerance develops, they up the dose and the frequency of use. Oftentimes, this is to avoid feelings of withdrawal. Withdrawal happens when the person does not take the same amount of opioids. Some of the symptoms of withdrawal include anxiety, nausea, vomiting, and abdominal pain. While symptoms can be severe, most of the time they are not life-threatening. More about withdrawal in the next clip. Typical withdrawal happens when someone stops taking opioids and begins feeling symptoms from their dependence. Just like quitting alcohol, nicotine, sugar, caffeine, the symptoms gradually decrease as your body recalibrates. But there's also a lesser-known type of withdrawal called precipitated withdrawal. Drugs that rapidly displace opioids from opioid receptors can precipitate withdrawal, which is a state of rapid and profound withdrawal. Precipitated withdrawal for an opioid-tolerant individual can result in a serious state of withdrawal with symptoms that include fevers, chills, bone aches, and dysphoria, a state of extreme unhappiness. It's important to know that precipitated withdrawal does not happen to opioid-naive patients because they don't have tolerance. Next, we'll get into the specifics of how naloxone works. Naloxone is an opioid mu receptor antagonist. Antagonist basically means blocker. It works by rapidly displacing opioids from the receptor and antagonizing and closing the receptor. Simply put, naloxone rips opioids off the brain and reverses an overdose. If someone has opioid tolerance, this may result in precipitated withdrawal, which can be unpleasant. In the next video, we'll talk more about how naloxone administration works. The gold standard for medical professionals is to titrate naloxone to respiratory effect using an IV. Basically, we give the smallest amount possible to the point where we have the person breathing again. All the while, we're managing the airway and breathing until the patient's respirations return to normal. However, this is an advanced medical skill performed by doctors, nurses, and paramedics. For the average person, a friend, or someone at a rave, these advanced skills cannot be taught in a short period of time. But administering naloxone is designed to be accessible by everyone. That's why we have naloxone formulations at higher doses. We'll cover more on naloxone in the next clip. What we can teach in a standard certification is recognizing the signs of an overdose, administering naloxone, and simple rescue breathing. Often layman rescuers at places like music venues, at home, walking down the sidewalk, they need the simplest way to give the medicine and the highest dose to ensure effectiveness because they don't have the advanced skills of a medical professional. It's recommended they use higher dose, 4 milligrams Narcan or 8 milligram Plexado, especially for rescuers at festivals or in places where they might encounter somebody experiencing an overdose because these people are more likely to be opioid naive patients. Next, we'll discuss more about opioid tolerant patients. For our opioid-tolerant patients, it's recommended that we use lower-dose naloxone because of their risk of precipitated withdrawal. Using lower-dose naloxone requires professional training because of the more advanced skills required. This is why we encourage our more experienced rescuers, like our friends in harm reduction, working in places like Skid Row, MacArthur Park, Portland, or Kensington, to use intramuscular naloxone and manage the person's breathing. But for those associated with more opioid-naive populations, check out the next clip to get a broader perspective. For our rescuers working in opioid-naive communities with high-level risk factors or who rescue less frequently, you'll want a higher dose naloxone because you can't afford to give too little. Naloxone does not precipitate withdrawal in people who are opioid-naive. And for our opioid-tolerant population, the severity and duration of precipitated withdrawal can vary. And not all people get precipitated withdrawal when an opioid overdose is reversed. Now, hypoxia is the medical term for lack of oxygen. And people recovering from hypoxia after being reversed by naloxone can have significant discomfort and symptoms that overlap with those of precipitated withdrawal. In recent studies with opioid users, including those that had experienced precipitated withdrawal, still preferred higher dose naloxone because they prefer to be alive. In the next clip, we'll cover intranasal options. These are the two intranasal naloxone brands, Narcan and Cloxato. Cloxato comes with 2 intranasal 8 mg doses, while Narcan comes with 2 4 mg intranasal doses. So Cloxato is twice the strength of Narcan. The medical community and the FDA recognize that synthetic opioids are 50 times more potent than heroin and 100 times more potent than morphine. Fentanyl is involved in more than 80% of overdose deaths in the United States. It causes rapid overdose and is much harder to reverse. And 1 box of Narcan with 2 4 mg intranasal doses is often not enough to restore breathing in somebody experiencing an overdose from fentanyl. For these reasons, more higher dose versions of naloxone are being developed and are being given FDA approval. Next time, we'll get into what tolerance means. People who use drugs or take medications may develop a tolerance to them. Tolerance results from changes in the number of receptors, the sensitivity, or both. For some people, tolerance is caused by escalating the dose or the frequency of their use. What can happen is the person starts using the drug more frequently or moves on to a more potent version of the same drug. They get an adverse physical response when they decrease or stop taking the drug. This is called withdrawal. Some of the symptoms include flu-like symptoms, anxiety, or depression. So when someone who's developed a high tolerance for opioids is given naloxone, they may end up going into something that is called precipitated withdrawal. Opioid mu receptors are responsible for a lot of critical physiologic functions, like response to pain, stress, mood, motivation, endocrine and GI function, and respiration, aka breathing. Opioids in sufficient dose or potency can slow or stop a person's breathing. This is how an opioid overdose death happens. More on precipitated withdrawal in the next clip. Drugs that rapidly displace opioids from opioid mu receptors can cause precipitated withdrawal, and this state is rapid and profound. Precipitated withdrawal for an opioid-tolerant individual may result in significant discomfort, including bone aches, nausea, vomiting, fever, and significant feelings of dysphoria. Naloxone is an opioid mu receptor antagonist. It works by rapidly displacing opioids from the mu receptor, and it blocks and closes the receptor. Displacing the opioid and closing the mu receptor restores breathing, but it may result in precipitated withdrawal. Though this is uncomfortable, it's often not life-threatening, but other risk factors can lead to complications. Whenever you revive someone, make sure you call 911 and they go to the hospital. Not all opioid-tolerant individuals will experience precipitated withdrawal. On the other hand, brain damage, organ damage, and death all occur within minutes of hypoxia, aka no oxygen, and this is irreversible. So not administering naloxone to someone who's overdosing from an opioid can be life-altering or fatal. Go to endoverdose.net, take the training, and they'll send you a free naloxone kit.